Greetings, everyone. So I think it's time that we get started. My name is Dr. Ian White, and on behalf of the Premier Health Network, thank you for joining our back pain webinar series. Tonight, we'll have representatives from Premier Health Neurosurgery, Premier Health Physical Therapy, and Premier Health Physicians Network. I'd like to thank each of you for attending this evening. I know we're all very busy with the holidays, and we're very glad to have you with us. Tonight, we're here to discuss back pain. And back pain is a pretty common problem. All of us either have a loved one or ourselves are dealing with back and neck pain. And the goal of this seminar is to provide you some insight into different treatment options that might help reduce your pain and get you back into increasing your mobility. Our panelists are experts in their given fields, and this evening they'll give you the treatment options in which they specialize in. And they'll try to answer all of your questions due to the Q&A sessions. If you want to click on the Q&A button, that will appear hovering over your cursor at the bottom of the Zoom screen, and you can type in your question. You may send your questions at any time during the presentation. There is also a chat button on your screen, but don't use that one, just use the Q&A button. Also, the seminar is recorded, and you'll receive a link to the recording via email in the next few days. So as I said, my name is Dr. Ian White. I am one of the premier health physicians in the neurosurgery department. And additionally, on our panel, we have Heidi Nellinger, who is one of our physical therapists. She'll be talking to you about conservatively managing your back pain. Michael Padero, who is one of our PM&R physicians, and Dr. Sujit Bimreddy is one of my partners in the Department of Neurosurgery. I'll give a more in-depth introduction to each of these, and they'll give you prior to their presentations. Dr. Bimreddy Padero and I practice at Premier Physician Network offices. We're also part of the Premier Health Spine team. And Premier Health Spine team, as the Premier Health Spine team, we try to take any of the hassle away from you for finding the right specialist. With that, let's get started on this evening's presentation. So back pain is a pretty important and complicated issue. There's a lot of different reasons to have back pain. It's very common in the population. There are estimates that 60 to 80% of the population either knows somebody or suffers from very bad back pain. It's in the top 5 of the most common complaints to primary care adults, and the top 3 reason for needing time off of work. Now, there's a lot of reasons to have back pain, but tonight we're just going to focus on the spine itself and structures related to the spine. Even with that said, there's a lot of different causes in the spine for having the pain. Example, nerve root compression, instability, alignment, or SI joint pain. So when you go to a physician or you get evaluated for your back pain, the basics is the pain, and some of the questions that you'll ask is the pain new or old? So this is important because we want to know, has the pain recently happened? Were you doing anything that exacerbated the pain, or is this pain that's been long-standing and why you're seeking evaluation today? Is the pain mainly in your back, or does it go down your leg? Is it mainly in your neck or go down your arm? Is it worse when you're bearing weight? So is it worse when you're up or laying down? Is it worse or better with activity? And then how excruciating is the pain? A lot of these things will be questions that you're asked, and all of these matter because they kind of help us formulate a plan and also get the appropriate diagnosis for you. So we'll go over a few of the most common back issues here, and all of the panelists will touch on these to some degree in terms of their treatment plans, but I thought just having an introduction would kind of get us off in the right direction. So the most common type of pain is myofascial pain. A lot of people, they'll be doing something and they'll feel a sudden twinge in their back, or this can be long-standing just from muscle fatigue. There are areas of the spine that are the attachment points, and these are noted by the white fascia. And this is a lot of times where the pain generates from, is these areas kind of in the low back area and then kind of along the spine. And I think this is because it's the most common cause of back pain. A lot of people think that there's something wrong with their spine when in actuality there's something wrong with the muscles. And the treatment for this is not surgical, it's actually just muscle strengthening. However, it can mimic a lot of things that seem like nerve problems or disc problems. The second thing I want to talk about is a disc herniation. This is probably the most common thing that people think about when they think they hurt their back. So it's generally you feel a pop or you feel some type of give way in your back when doing an activity. The disc herniation itself can be incredibly painful. And denoted in this picture, you can see by the red kind of herniated disc, you can press against a nerve, and that's what most people kind of believe is sciatica. And it generates that pain, that burning electric pain that shoots down your leg. Spondylolisthesis is more commonly known as a slip disc. It's caused by instability of the spine. And when the spine is moving in an unstable way, it pinches the nerves. And in doing so, you can see that it would be episodic. So occasionally you will, if you move in the wrong way or you're doing the wrong activity or an activity that puts a lot of pressure on the spine, there'll be a pinch. And that can last from anywhere from a few hours to weeks in terms of pain. Patients that have these recurrent bouts of pain oftentimes do have a slip like this. And then the last thing I want to touch on is SI joint pain. So this is one of the common things that patients will come to me saying, it hurts kind of in my butt area. The SI joint is a large joint that where the pelvis touches the sacrum, and it is doubly innervated. So it actually has two innervations. So it can mimic a lot of the different types of back pain that we described. And it also can mimic the pain shooting down the leg that we referred to as sciatica in the last slide. So there's three pillars of treatment. We generally go from the most conservative to the most invasive, depending on, and we always want to start with the most conservative treatment. And that generally is physical therapy. And physical therapy has been shown to help 98% of patients. So patients who strain their back or have a disc herniation, generally these are problems that get better. And with physical therapy, it's been shown that the majority of patients do get better. If that's not working, then we move to interventional type of pain procedures such as injections. And then surgery is the last line treatment. These are our panelists, and I will be introducing them as they come on, then we'll provide a Q&A session at the end of each of the presentations. So our first panelist is Heidi Nellinger. She's a physical therapist that works at Premier Health in the physical therapy department. She received her degree from Ohio State and has been practicing for 26 years. Heidi specializes in orthopedics and sports medicine, and she mainly sees patients at Miami Valley South.
All right, thank you, Dr. White. First, thanks to all of you for taking time out of your evening to come to this. I'm honored to be a part of the panel and to have been invited to talk. So I'm here representing the physical therapy crowd. So I thought I'd just kind of walk everybody through what happens when either you self-refer or your doc refers you to physical therapy for your back pain. Many of you may have been to physical therapy, so some of this may be redundant for you, but some of you, it may be brand new stuff. So the first thing that's going to happen is that you're going to receive an evaluation by a physical therapist. And just like with any intake visit, there's going to be some paperwork, and people tire of this, but it's really important for us as physical therapists to get a good medical history. We don't always think of that when we come to physical therapy, but we need to know all the other comorbidities that you have going on that may be impacting your back pain. We need to know lots of information about the behavior of your pain. And we also want to know quite a bit about your function, what kind of functional limitations you have, what kinds of things you can't do because of your back pain, what kinds of things you'd like to be able to do. So all of that kind of comes through on our initial paperwork. And then when you come to your visit, the physical therapist will take you back to the treatment area. And the first thing you're going to do is you're going to talk. I always tell my patients, I want to hear your story. So that means that I want to hear what brought them into the clinic, what kind of pain do they have. Dr. White hit on a lot of these things, the location of the pain. We are very, as physical therapists, really all we have is the exam, the physical exam and the subjective exam, the history that we take from you. So this is really where we really need to get the money information from you. So we need to know if you had an injury, what was the mechanism of that injury? How did you do it? Were you lifting a couch? Were you bending over, brushing your teeth? And then just lots of information about the pain, because we need to know what kind of factors aggravate your pain and what kind of things relieve your pain, so that then that helps to dictate the treatment going forward. So, basically in the history and in the physical exam, as physical therapists, we're movement specialists. So we are looking for the mechanical cause of your pain, meaning what mechanics happen in your body that bring on your pain. Is it standing? Is it sitting? Is it bending over? That's what we're doing as we're going through the exam with you. And again, we're also very keyed in on function. We want to know what kinds of things that you can't do as a result of your pain and what you want to get back to. So after we get done talking and chatting and hearing your story, then we're going to go on to the physical exam. And again, this, physical therapists cannot order x-rays. We don't do injections. We don't do surgery. So we are putting all of our money on that physical exam to be able to get the information that we need to prescribe a treatment plan going forward. So this is where we do lots of testing. We have you bending and moving. We test range of motion. We test flexibility. We test strength. We do things like look at your posture. We do things like check your reflexes. We have lots of special tests we do to try to figure out from our perspective if it's coming from your SI joint or if it's coming from your disc or if it's coming from someplace else. So we do a lot of movements with you in that physical exam. Once we collect all that data from the history and then the physical exam, then we're going to sit down and talk. We're going to go over what kind of findings there were in that exam. As a PT, I'm going to tell you what I think might be going on. When we, as physical therapists, we are really educators as much as we are healthcare professionals, because that's the most important thing to me, is that my patient understands what's going on with them and why their problem is what it is and what they can do to fix it. So from there, then we make a plan. We make a treatment plan. Usually I sit down and I say, well, here's the plan that I propose, because it's really not my plan for the patient, it's the patient's plan. So together we work on coming up with some goals and some paths to get there. And in physical therapy, the reason I'm not talking about details of what we do in physical therapy is because depending on the person, depending on the PT and their area of expertise, there's a plethora of things that we can do with patients and their problems. We have, manual therapy. We have exercises. We obviously always try to prescribe some type of exercise. We do a lot of posture education, a lot of ergonomic education, looking at your workspace and how that can be better to not contribute to some of your pain. And then we have some modalities that we use, some of things like traction and electrical stimulation, some things like that you might be familiar with. So all of those things may or may not be as part of the plan. A big part in my notes here, I wrote that a big part of what we do in physical therapy too is we're trying to manage patients' expectations. I think a lot of people come to physical therapy thinking that they are going to get fixed. And really what we're trying to do is we're trying to equip the patients with the tools to take care of their problem themselves. Because I think the statistics are, once you have back pain, and this is an unfortunate statistic, but about 90% of the time you're going to have back pain again. We just have bad habits, whether it's how we sit, how we work, and things like that, sports we play. So we want to, as physical therapists, we want to help guide you, but we want to basically give you the tools to help manage the problem yourself. So there's just a lot of patient education that goes into what we do. And then, part of the plan is how often you're going to come in to see us and how long we think that's going to take. Physical therapy is not meant to be a lifetime situation for people. We're trying to set some goals with some reasonable timeframes and really get you out of physical therapy. We'd rather see you at, our Charlie's or something like that. So that's our goal, is to get you equipped with the tools to manage the problems yourself. But, I think if you take anything away from this talk, is the importance of the patients being educated about their problem, about what kind of factors go into their problem causing the pain, and then what kinds of things they can do about it, and giving you as many things as possible to take care of that. So with that, I'll send it back to Dr. White.
Heidi, we have a question here from the panel or from the audience. And it's, is there a physical therapy type treatment for pinched nerves with sciatic pain?
Wow, that's a tough one. I mean, there are lots of things that we use for that. Again, it depends on the movements that create the irritation to that nerve. I mean, sometimes we do things like traction, and sometimes we do things like a McKenzie extension program. It really just depends on the forces that are going together to create the pain for that. So unfortunately, there's not really a one size fits all plan. And that's where that physical exam comes in. That's really important to try to get down to the crux of the matter as far as what's creating the pain.
I think some of these questions will be addressed kind of holistically. One of the questions is, what physical therapy treatment would you recommend for a patient with facet arthropathy? A lot of times when there's arthritic changes, in the joints in the spine, what our goal is to try to unload those joints. So a lot of times we do exercises in which open up those facet joints and take some of the compressive forces off of that. So we may do what people would refer to a little bit more as flexion type of exercises. But again, when we examine someone for back pain, even when we know that the problem is underlying arthritis, we're going to do a thorough exam, because we need to see if flexibility problems in their hip flexors and their quads are contributing to that pain. So there are a lot of things that we can do to try to restore the balance to the area, if you will, to reduce the pain. I have a question here. Thank you for that answer. This question is, what is traction?
What is traction? Traction is a device that we utilize in physical therapy, where it secures if you're looking at lumbar traction for the lumbar spine, there's a strap that secures the upper part of the trunk, and a strap that is connected to a mechanical device around the hips and pelvis. And basically, we pull with a force to try to separate and decompress the joints of the spine. It's a decompression device, best explained.
I have some other questions here that I think I might actually be okay to answer. If a chiropractor cracks your back, is that dangerous to the spine? Generally, the chiropractors are not dislocating your spine. They're just basically trying to mobilize the individual segments. I'm more of a fan of the micro manipulation rather than the whole spine manipulation, because I think it's more controlled. But I don't think that cracking your low back is dangerous to the spine. I have seen complications with cracking the neck. And so I think, especially in young females whose ligaments are a little bit looser, cracking the cervical area is something you should do with more caution. There's another question, recommendation for spondylolisthesis. I will defer this to later in the talk with Dr. Pimready. And there is a question about 16 years of back pain, several years ago referred to Premier Health for 6 weeks of physical therapy. It did not help, but has an MRI with ligamentous overgrowth, moderate central canal stenosis, but is not bad enough for surgery. Recommended deep tissue massage. Heidi, what is your stance on deep tissue massage?
I think that if the issue is a soft tissue problem, I think that deep tissue massage can be beneficial. Again, it's all about what is the the engine of the train. A lot of people with back pain, one of the things I tell them is that, what you have going on is, if you think about a train with lots of cars in it, there may be multiple factors that may be contributing to your problem. You might have some arthritis in the joints. You might have a small disc herniation. You might have some soft tissue. We need to figure out which one is the engine of the train and direct treatment to that first. So if soft tissue is the engine, then soft tissue is definitely a viable treatment.
And this question, I actually have seen pretty good results with this from my patients, but have you found that dry needling helps relieve pain? What is it indicated for? And then also, what's the difference with scraping?
What's the difference with what? I'm sorry, I didn't hear that one.
Scraping and dry needling, what is the difference between those two?
I don't know. And I do not utilize dry needling in my practice. I'm not trained for that. So I do know that my colleagues do it and have some success with it, but I would be remiss if I commented too much on that, since it's not a part of my clinical practice.
So we can move along. Thank you, Heidi, for answering those questions. There were quite a few. The next panelist is Dr. Michael Padero. He graduated from the University of Dayton. He attended medical school at the University of Cincinnati, where he performed his PM&R physical medicine and rehab residency. And he served as chief resident there as well. He is an active member of the American Academy of Physical Medicine and Rehab and is board certified. He is additionally a professor at Wright State School of Medicine, and his practice centers around rehab and electrodiagnostic studies. Dr. Padero.
Thank you, Dr. White, and thank you to the other panelists and to everybody who's joined tonight. Appreciate your time. I'm a physiatrist. I'm a specialist in physical medicine and rehabilitation. What that means is I'm trained to assess conditions of the spine and the musculoskeletal system in a conservative manner. So we use non-surgical treatment to try to avoid surgery for neck or back pain if possible. If you come to see a physiatrist, a lot of what will happen is similar to your evaluation when you'd see somebody like Heidi or Dr. White. You'll get a comprehensive physical examination. There'll be focus on your pain, on your function, what previous treatments you've had, what works, what doesn't work. We'll focus on a musculoskeletal examination, again, focusing on the spine, but also looking at other things that can mimic spine pain. We'll look at what imaging or other testing you might have had. It could be lab work, it could be electrodiagnostic testing. And based on the history of the physical examination, the testing that you've had, we're going to try to determine what the source of your pain is and how best to manage it. If appropriate imaging or testing hasn't been done, then we'll talk to you about focusing on what we need to look at to try to determine what your pain generator is. As Heidi says, what's the engine that's driving the train of your pain? Once we do that, we'll provide education. If you've got imaging, we'll look at the imaging. We'll determine if what we see on that imaging correlates with what your pain is. As we get older, a lot of people get bulging discs on MRIs in your spine. Not every bulging disc is a problem. Not every bulging disc causes pain. So some of what we do is educate, is this radicular pain? Is it more somatic pain from the muscles, myofascial pain, as Dr. White mentioned? Is it ligament pain? Is it joint pain like the SI joint or the facet joints, as we've mentioned? Once we do that, we work in a collaborative approach with other specialists to try to manage the pain. We will work with medications, if appropriate, to treat somatic pain, to treat muscular pain, to treat neuropathic pain. That may be oral medication, maybe topical medication. We may recommend injections. For instance, for myofascial pain, trigger point injections can be very helpful. As Heidi mentioned, dry needling can be an option. We work very collaboratively with physical therapy. So when we see the patient, we try to design a therapy program with the therapist that integrates the type of treatment that's going to best give the most likelihood of improvement, be that traction, be that exercises, be that manual therapies, be it mobilizations, which is like micro manipulation. But we really want to work with the therapist. We provide them comprehensive information. We can link with the therapist. So if the patient is not responding, we can look at altering the treatment to see what we can do to try to maximize their improvement. Heidi and I both came into the system almost at the same time, so we've kind of grown up together in Premier. One of the things that I think over 26 years that's been helpful to me is, as Heidi mentioned, different therapists focus on different things. I know what therapists focus on facet pain or SI joint pain or myofascial pain, so I can try to help guide the patient to the therapist who might be most helpful in improving their function. If people don't respond to therapy and medications, then we can educate them as to what the next steps are in that ways that they can get better, be that interventional treatments like injections or referral to surgery to see if surgical options are appropriate. But that's basically what we do, but we focus on restoring pain, relieving pain and restoring function. That's really, the holistic approach we try to take in helping people get better and overcome the pain and the functional impairments they have from their neck or back pain.
So thank you, Dr. Padero. There's some questions here.
Sure.
A few of the questions are centered around the use of steroid medications and just the use of injections. So I know it's not a huge part of your practice, but one of the questions was, I recently had a cortisone shot in my back, but the relief lasted less than a week. Is that common?
That would depend on a lot of functions. When you talk about a cortisone injection, some people see their family physician, they just get a generic cortisone injection, which will decrease inflammation and generally is short lasting. Other people will get directed injections into the facet joint, the SI joint, or into the epidural space, which are image-guided injections, which typically should give longer standing relief. That's not always the case, but you're hopeful to get 3 months or more of relief. And oftentimes, the injections are part of a holistic plan. A lot of times people come in and they can't tolerate therapies initially. They'll get an injection to get them over that acute pain or that more severe pain, and then they can see Heidi or one of the other physical therapists and then really work on a functional restoration program with stretching and strengthening and conditioning to try to get better once the pain level has come down a little bit.
I have another question here. How does traction compare with inversion?
Inversion is just another type of traction. Inversion tables are basically when you get strapped into boots and hung upside down. It's generally not something we recommend. Traction is a better option. Some people can run into difficulties on inversion tables. I certainly know people that use them successfully, but it's not a large part of what we do, but it's just another means of doing traction that people can do at home.
I have a question here that I can answer. So this patient had an L4-5 fusion. I'm guessing 10 years ago. It says 10 hours ago, but 10 years ago. She has ongoing pain to her lower sacrum and left side since before surgery, pain to sit, walk, etc. She is wondering if this is all related to her back and what type of help should she seek. So there's a number of different reasons that you could be having ongoing pain. One of the most common things is just there was an abnormality on your MRI, which you got the fusion for. However, you have another pain generator. You can seek another opinion or go back to that surgeon in terms of trying to find out, is it your SI joint? Is it your muscles? Have you not rehabbed adequately, and seek guidance in that fashion. But if you're having severe ongoing pain, there are other options for you. Given the back, another question, given the back pain is due to muscles and other soft tissues, quite often, why don't doctors order MRIs before sending patients to PT? There's a few different reasons for that. One is honestly insurance. So insurance companies generally want you to try to get better before they do advanced imaging. The other thing is a lot of patients, within a 6-week period will get better from acute back pain and not necessitating an MRI. We have another question here. As we get older, our goal is certainly to live as pain-free as possible. What physical therapy treatment would show the best possibility to treat degenerative disc disease? I'll defer to you, Dr. Padero, on that.
Well, I think, as Heidi said, you really have to look at each individual patient, but to treat degenerative disc disease, from a conservative standpoint, you really want to work on core strengthening, you want to work on aerobic conditioning, you want to work on maintaining good flexibility throughout the pelvic region and the lumbar spine and the lower extremities. You want to use good posture and body mechanics and avoid the types of things that can aggravate those conditions: improper lifting, improper body mechanics, improper posture. You also want to look at things like your body habitus. Are you in good health? Are you eating properly? Are you maintaining a good weight? Are you avoiding tobacco? Because tobacco can make degenerative disc changes worse. What are your work demands, or what are your hobby demands? And if what you're doing, is there anything that you're doing there that could aggravate your pain? And do you need to look at different ways to do it to modify those activities?
So is there the treatment of injecting a steroid into a bulging disc? Is this still used?
Is that a question for me?
Yes, sorry.
I'm sorry. Generally speaking, epidurals are done into the space around the spine, not into the disc itself. There are, prior studies where chymopapane was injected into discs. I don't believe that's used very often anymore. There are studies that look at, growth factors and other things that have been injected into discs more experimentally, but to my knowledge, intradiscal steroid injections are not commonly done at this point in time.
I have heard of the growth factors. I think there's plasma that people inject in.
Yeah.
These are met with very mixed results. I don't think there's any study to show that it's efficacious. So, and a lot of those treatments are out of pocket. So because there's not a lot of evidence towards it, insurance companies just generally don't want to pay for it, and it becomes very expensive with minimal relief, in my opinion. Another question for you. I'm told that a nerve burn is a procedure where the nerve is burnt and then will grow back shorter. Is this a possible way to reduce herniated disc pain?
Generally speaking, when people talk about burning a nerve, it's usually a radio frequency ablation, and that's used more for facet joint pain, where you'll do radio frequency ablation to the medial branch that goes to the facet joints. The nerve is denervated. It's a nerve that carries pain signals, but is not important in muscular function. So you don't lose muscles by doing this. Generally, the pain relief is somewhere between 6 and 9 months, and the nerve will eventually regrow, and the pain can come back over that time period. And then it can sometimes be repeated, and sometimes with subsequent injections, the effect can last longer, like 9 to 12 months. But actually burning the nerve root itself, like the lumbar nerve roots or the cervical nerve roots, is not something that's typically done to treat nerve-related pain. It's more, like I said, facet-mediated pain with radiofrequency ablation.
When would you recommend a mild procedure, MILD?
I'm not familiar with the mild procedure, I'm sorry.
I think the mild procedure is basically the RFA.
Oh, okay.
So
yeah, so I would recommend that in somebody who's got clearly facet-mediated pain based on their history and examination, and they haven't responded to other conservative treatments like medications, physical therapy, topical treatments. And generally speaking, what will happen is you'll either get a facet joint injection or a medial branch block, which is an injection that blocks the nerve to the facet joint, usually the facet above and below it. And you'll see if there's relief of pain with injection of a local anesthetic and a steroid. If you get, more than 50% relief of pain that lasts for the duration of the local anesthetic and the steroid, then you'd be a candidate for the medial branch block.
So thank you, Dr. Padero. Actually, there's one more question that I think relates to you. Have you heard of piezo therapy?
I do not know much about it. I've heard of it, but I've not seen any studies that really have suggested it's something we incorporate. So I don't have much expertise in it, to be honest.
Okay. So our next panelist is Dr. Bemready. He is one of my partners at Premier Health Neurosurgery. He graduated from St. Louis University Medical School, and as well as that was his undergraduate degree. He did his neurosurgery residency and complex spine residency at Peoria School of Medicine.
Hi, everyone. Thanks for having me. And thank you for the audience for joining us today. So I'll be talking to you about back pain and nerve pain from a neurosurgical standpoint, from a surgery standpoint. As Dr. White mentioned, a lot of people are affected by chronic back pain and neck pain, and usually they're referred to a spine surgeon, whether a neurosurgeon or an orthopedic trained spine surgeon. So a lot of people are referred fairly early in the process. And anytime I see patients who were referred to me from the PCPs with back pain, I always check and I always talk to you guys, ask the questions that Dr. White mentioned earlier about the chronicity of the pain, where does it go, how bad does it get, and also other important questions such as, what have you tried so far to help with the pain? As Heidi mentioned, a lot of times physical therapy is the mainstay of treatment for back pain. And if I see any patients that haven't had any physical therapy, I order and refer them to a physical therapist, because usually surgery should be the last resort for any of any back pain or pinched nerve issues, because that's the most invasive and probably carries the highest risk compared to the other treatment modalities. And as we've talked in the last 30 minutes, a lot of the back pain improves with physical therapy and other non-invasive methods. So I always refer them to physical therapy if they haven't had it. Sometimes patients will say, well, I'm already in a lot of pain here, so I don't know if I can do physical therapy. Well, I think it's really important to try that, just because that's a different way of training your muscles to be more efficient in doing their jobs. So the myofascial pain that Dr. White referred to, your muscles are tired and can produce back pain. So physical therapists can give you exercises and help you your muscles work more efficiently in trying to alleviate that back pain. Help out with that. And I think it's really important to at least try it. And vast majority of the patients that I see that haven't tried physical therapy, once I recommend it, they go to a physical therapist, their back pain significantly improves. Then from a purely surgical standpoint, I'm looking at a couple different things in order to see if I can help out the patients as a surgeon. The first thing is a nerve pinched. So this can happen through from a variety of reasons. A lot of times people have heard of disc herniations or slip discs. They can produce pressure on the nerve and cause pain that usually radiates into either the legs, or if it's in the neck, it can cause pain in the arms. Another thing is if there is a lot of arthritis, bone spurs that are causing pressure on the nerve, that can cause pain that radiates into the legs or the arms again. And just degenerative disc disease, or when your discs are undergo degeneration as we age, the nerve tunnels where the nerves leave the spine, they can become smaller, and then that can cause pinching of the nerve. So that's one thing that I'm looking for in terms of whether I can help out a patient or not. Other things that can cause back pain are obvious deformities. So scoliosis, patients that are their spinal alignment or spondylolisthesis is pretty severe, that can cause back pain, but also it can also cause nerve pain from pinching the nerves. And also a very minority of the patients that have back pain, some tumors and other pathological processes can affect the bones, causing severe back pain. So I'm looking for mainly these things that are causing active pressure on the nerve, or some sort of deformity, or something that makes the spine unstable that's causing the back pain or the leg pain, and see if surgery would be a good option for the patient. Usually with disc herniations that are causing pressure on the nerve root, the body will heal the disc on its own. Majority of the patients can get better. Their pain can improve with time on its own. Surgery can do it a little bit faster, but usually if you look at studies that go out to more than a year, the pain levels of people that have been operated on versus people that have not been operated on are similar at that stage. So even with this, with a slip disc or a disc herniation, the first step would be a non-invasive treatment modality such as physical therapy, or after that, a little bit more invasive, such as injections, epidural steroid injections that can decrease the inflammation of the nerve before going to surgery. As a surgeon, if there is pressure on the nerve that's causing pain that goes into the leg or into the arms, we are a lot better at treating those with surgery, those type of problems, than purely back pain or purely neck pain, because as all the panelists so far have mentioned, there are so many different factors that can cause back pain. It's hard to pinpoint one thing that can be improved with surgery. Whereas something that causes pinching of the nerves, it's easy for us to see what's causing the pinched nerve, and we can usually fix it, whether it's a non-fusion surgery where we just do a laminectomy and a discectomy, remove the disc and remove some of the ligament or the bone spurs in the process, or if the disc herniation, depending on the location, some people may need a fusion type of surgery in order to help with the pain. But typically surgery is the last resort. I guess I can move to the questions now.
Yeah, so Dr. Bimready, thank you for your presentation. I think one of the things that patients kind of fear is when I'm referred to a surgeon, is the surgeon just going to offer me surgery regardless of what I have? Like if I walk through the door, am I getting surgery?
Yeah.
I think that's what you're communicating is
Yeah.
that we will holistically evaluate you. It's not just a one-trick pony.
Oh, sorry.
There's a question that's, what is the recommendation for spondylolisthesis? Is it cortisone shots? Can they get away with physical therapy, or is it straight to surgery?
Yeah, so for spondylolisthesis, typically the first line would still, so first it's, I would want to see what grade of the spondylolisthesis is, how severe it is. But usually physical therapy and physical therapy will be the first line there. Even with spondylolisthesis, there's a little bit of a slippage of the one of the bones on top of the other, and with physical therapy, training your muscles to be more efficient in trying to control the movement between those bones, I think that can help patients a lot, and hopefully avoid surgery. If physical therapy doesn't quite do it, then we can also do injections, target those specific nerves that are being pinched by that spondylolisthesis, and see if that would help alleviate the pain or decrease the inflammation, so that the patient can be evaluated and can participate in physical therapy, improving their back muscle function, and thereby improving their back pain. I think even in those situations, surgery would be the last resort. If you walk into a surgeon's office and they don't, and you haven't done anything such as physical therapy, any other injections or anything like that, and you don't have any obvious weakness or anything like that, and they're offering you surgery, I would say to stay away from that.
So we have another question that's about this patient's 87-year-old mom with severe spinal stenosis in the lumbar area. When she was in her early 70s, surgery was recommended, but she was more afraid of having surgery at that point. As she's older now, her condition has gotten worse with walking, and walking has become more difficult. She has very bad pinching nerve pain. The pain is basically in her thighs when she sits, laying down, and bending helps alleviate the pain, and medication, however, medication doesn't help much. Do you think a minimally invasive laser spine surgery would be safe on her?
I have seen, I don't have any personal experience in performing any of the laser spine surgery, but I have seen some of the results, and usually in my training, I have seen patients that have undergone laser spine surgery, and it doesn't seem very helpful to me based on my experience. I don't know what Dr. White's experience is with that, but I probably wouldn't recommend that. If there is stenosis, we had to take into consideration the age and the overall health. But I think surgery is an option. Osteoporosis doesn't necessarily take surgery off the table. If she has tried everything, including physical therapy and injections, surgery may be an option, but it's hard to say that without specifically looking at the patient, evaluating the patient, and evaluating the imaging.
So my thoughts on surgery for somebody that's in their 80s is always, do they absolutely need the surgery? It sounds like your loved one is miserable. There are a lot of minimally invasive options that we offer. And so does she have the right pathology? Are symptoms perfect? And then also just the overall health. So if we can take them to the OR safely, then and relieve the symptoms, then we definitely can do it. And the minimally invasive things that you mentioned, they do help in terms of lower blood loss, smaller incisions, things of that nature. But overall, we would have to see the imaging and kind of equate the health of your mom with that. Next question is, I've had 3 lower back surgeries through the Laser Spine Institute. Laser Spine Institute apparently is good at marketing, which didn't help. I have spinal stenosis and osteoarthritis. The pain really hits in the evening, very painful. Sometimes I can't sleep several times, 36 hours or more. Is there anything that can help me?
Yeah, this question is difficult to answer without specifically looking at the imaging to see if there is something that can be treated, done there through surgical approach to treat that from a surgeon standpoint. But I'm not sure if you already tried physical therapy, and I think I would probably start at that. But I'd have to specifically talk with the patient, know history a little bit more before saying if there is no hope. Usually there is something that we can do to kind of help out.
So there's another question. How do I figure out the right type of specialist to schedule for pain in my buttocks area that started in my lower back from a simple lift and twist motion?
I would probably start with physical therapist first, and if that doesn't help, then I think getting an MRI is a reasonable option after that, and then kind of depending on what the MRI shows, going to a surgeon versus going to a pain management physician. Both of them are reasonable. If you come to a surgeon first, they might refer you to the pain management doctor, or if you go to the pain management doctor, they will perform the non-invasive or less invasive procedures first. prior to referring you to a surgeon if they think there's a need for that.
Do I need a doctor's order to go to physical therapy? I can answer that. Generally, yes. However, I think it's pretty easy to get into our clinics. We're happy to evaluate you and send you to physical therapy. This can also be done through your primary care physician. What is the treatment for spinal stenosis? I will defer to you, Dr. Benready, on that.
So treatment for spinal stenosis really depends on the symptoms of the patient. If you're having severe pain that's going down into the legs, causing lifestyle difficulty with your daily activities, then I think I would start with physical therapy. If that doesn't seem, because by doing the physical therapy, you can learn different ways to manage the pain where your body is able to tolerate it. If that doesn't work, then certainly surgery is an option. But I think there are less invasive options than surgery, such as injections. That Dr. Padero mentioned. Could be, we can start with the injections and then proceed to surgery should you need it based on the imaging.
So the last question I have here, when can surgery be an initial recommendation for back pain? This patient had sciatica and the recommendation was to go through physical therapy first. Those 3 weeks were excruciatingly painful. And they ordered an MRI, which showed a herniated disc. And then this resulted in a microdiscectomy. I can answer this. So it's very difficult because in order for us to do surgery, we would need an MRI. And generally it's kind of chasing your tail, but a lot of times the insurance companies will say you need to do 6 weeks or at least fail physical therapy. If you come to the office and you have a disc herniation on your MRI, and it's a massive disc herniation, it's causing weakness, or it's just basically causing you the inability to walk, or something in your neck that's basically causing pinching of the spinal cord. These are situations where we would at least present surgery as the initial option. Now, a lot of times physical therapy will be a prerequisite to having the surgery anyway, even if we recommend the surgery. So a lot of times a little bit is dictated by what your insurance provider will tell you as well. But there are situations where we recommend surgery up front. So thank you, Dr. Benready, for your presentation. Thank you all to all the panelists. I know that it's getting late. For more information about our panelists and their practices, and their bios, we'll send along access to these tonight. The seminar was recorded and we'll email you a link of the recording. And along with that link, there'll be a short survey of tonight's program.